Thank you for the Neuroradiological Society of Nigeria for inviting me for this talk. And I'm very glad that I get the chance to speak in front of you all. So today I'll be talking about the posterior cranial fossa cyst, a snapshot of the key concept. Before I start, this is my conflict and disclosure that I have no financial disclosure with the material of this presentation. And all the cases that I'm going to show you in this presentation are going to be from my department. All the diagrams and information, some of the diagrams information I've taken from the different educational site as the mentioned below. So just give me a minute. Okay, fine. So these all are the posterior cranial fossa lesions. But when I was a resident, they all looked like the same to me, uh, just like these cute little neonates, ball neonates. So whenever there was a posterior cranial fossa cyst, I was always confused because they all look same. So then what happened if we miss the diagnosis? Not all posterior cranial fossa cysts are the same. So we all know that the cystic malformation in the posterior cranial fossa are frequent finding in MRI in pediatric brain. Then why does accurate diagnosis matter a lot? It matters a lot because we need to ensure that we are doing the correct diagnosis on imaging to help the physician to make the appropriate or decide about the appropriate clinical management. It also helps to predict the neurodevelopment outcomes, especially for our pediatric neurology and neonatology colleagues. And it also helps our geneticists to help to identify the correct genetic inheritance and predict the risk and recurrence and guide the genetic counseling and for the family planning, especially for the couples who are having the kids with the large posterior cranial fossa cyst. And the most important thing to remember is early and precise imaging is the key for the better outcome for these children. But now I want all of you to have a pause and think in yes or no manners because I'm going to put the few questions in front of you. If you would like to answer these questions right now, you can write down in the chat box and I'll be seeing your questions. But think about it and let's see what could be the answer. So my first question to you is the Blake's pouch a brain malformation? Do you think it's yes or no? My second question to you, are the term Dandy-Walker variant, Dandy-Walker complex, Dandy-Walker contorium are appropriate to define the cyst of the posterior cranial fossa, which includes Blake pouch cyst, inferior vermian hyperplasia, and megacysterna magna. I wanted to ask if something which is not totally like Dandy Walker or not fulfilling the criteria, can we use the word the Dandy Walker complex or not? How do you do that? How do you use in your report? Do you say, what do you think? Should we use this term? Yes or no? Then my third question to you, in a cystic hindbrain malformation, whenever you have any cystic malformation in the posterior cranial fossa, what do you think? Which factor influences the neurodevelopment or cognitive outcome in these children? Do you think it's the Vermeer hypoplasia which predicts it? Do you think it's the additional supratentorial abnormality predicts the neurodevelopment outcome? Or do you think it's the severity of the presence of hydrocephalus? So I want you to think about at least these three questions. And now my fourth question is going to be this challenging case. So let's see this case. The clinical clue is that this child presented with an enlarged head. So what we are seeing right now in the imaging is a mid-sagittal section, T2 MRI. We are seeing a dilated fourth ventricle here, which is communicating with the large cyst in the posterior cranial fossa. As I hope you all can see my arrow. And then you can see the vermis, which is here, it's totally slightly elevated, but it's normally formed. And this is associated with mild hydrocephalus. So these all are the clues which are available on imaging. Now, my question to you, considering all these imaging findings, what do you think? What is the appropriate diagnosis? Is it Dandy-Walker malformation? Do you think it's a megacysterna magna? Or do you think it's a black pouch cyst? Or do you think it's just arachnoid cyst or inferior vermeil hyperplasia? Think about it, look at the image, and we are going to I'm going to uncover the question answer of these questions during my talk or at the end of my talk. Think about it. So that's the question that you need to that's the image that you need to keep in mind. So objective, what I'm going to do, or what I'm going to talk in detail. So this is the layout of the today's talk. We are going to review the important anatomical landmark of the posterior fossa. We are going to learn a quick systemic approach to the enlarged pericerebellar CSF spaces in the posterior cranial fossa. And we are going to review the main cystic pathology based on the proposed systemic approach that I'm going to give you. And at the end, as I said earlier, we are going to answer the question that I just asked. So embryology is a must before we start because it is the foundation of life. If something goes wrong at this stage, it doesn't just affect the brain, it shapes everything in our life. The physical
Hello.
health, the mental health. Yes. Uh, can you hear me? Should I carry on?
Carry on, please.
Okay, sorry. So as I said, the embryology is must before we start. So it's the foundation of our life. So if something goes wrong at this stage of the life, it does not only affect our brain, but affect every aspect of life, even the social life, mental life, health, everything. As we know, the basic building blocks define the rest of the structure of the building. So we will start from the embryology. So brain start forming at the 4th week of gestation with these 3 primary vesicles. So these three primary vesicles are actually the porencephalon, mesencephalon, and rhombencephalon. And the distal to this 3rd vesicle is the spinal cord formation. In the next stage, the porencephalon divides into the telencephalon and the diencephalon. Telencephalon gives formation to the cerebral hemisphere. Diencephalon further divides into the hypothalamus and thalamus. And in the next stage, mesencephalon, which is the 2nd vesicle for the brain formation, does not show any division. So it remains the same and gives the formation of the midbrain and give the formation of the midbrain. Now talking about the rhombencephalon, which is the 3rd. So I just flipped this image. So this is again your telencephalon, the diencephalon, the mesencephalon, which is the midbrain. And look at this portion, which is the last, which is the rhombencephalon. So the 4th ventricle start forming from the dorsal spect of the rhombencephalon. The ventral part, which is this part of the rhombencephalon, it gives to the formation of the pons, and the distal portion gives the formation of the medulla. But the dorsal portion, as I said, of the rhombencephalon gives the formation of the 4th ventricle. So 4th ventricle start forming from the dorsal spect of the rhombencephalon. So remember these primary vesicles. Now, further, if we further dig on into the 4th ventricular normal embryology, so this is the 3rd vesicle or rhombencephalon vesicle, which further is divide into the, as I mentioned earlier, the ventral portion, which is making the pons and the medulla. The dorsal spect, which was forming the 4th ventricle, it has the 2 stages. And number 1 stage, the superior portion start making the cerebellum, which is also known as AMA, which is the anterior membrane area. The superior portion of dorsal rhombencephalon gives the formation of the 4th ventricle and the cerebellum. The distal portion or the below portion of the rhombencephalon shows that cystic dilatation, and that cystic dilatation is called as Blake pouch. So between the 6th week of gestation till the 12th week of gestation, a cystic structure is formed from the posterior membrane area. So remember your anterior membrane area, which gives the cerebellum or form the cerebellum and 4th ventricle, and the posterior membrane area or the dorsal part of the rhombencephalon gives the Blake pouch. Before the 12 weeks of gestation, within this Blake pouch, a small hole starts appearing and it starts showing the fenestration. And as soon as it starts showing the fenestration, this Blake pouch disappears. And this foramen or this hole which appears after which the Blake pouch disappears is actually the foramen of Megandy. So as soon as the foramen of Megandy is formed, the black pouch by the 12th week of gestation disappear, and then you see this free flow of the CSF from the foramen megaly. Before that, the CSF flow was occurring through the foramen of Lashka, which are the lateral foramen. So, what is the black pouch rule? It's a normal early structure and should disappear by 12 weeks of gestation. And that's the first question that I ask you. Is this the black pouch is an abnormality? The answer is no. The black pouch is not the abnormality. It's a normal structure which disappear by the 12 weeks of gestation. Now, let's talk about a gross overview of the types of posterior canal fossa cyst and cystic lesion. So what we have is, in the posterior cranial fossa, we have the two type of cystic lesions. One is a true cystic lesions within the cerebellum, and the other are the congenital cystic malformation. So if we talk about the congenital cystic malformation, they can be extracerebral lesion or the intracerebral lesion. Or if we talk about the posterior cranial fossa, true cystic lesions, these lesions can be tumor, these can be infectious lesions such as abscess, hydatid cyst, or the benign appearing tumors such as epidermoid and cystic astrocytoma. But today, just filter out this cystic lesion. We are not talking about this. So what we left is, now we are left with the congenital cystic malformation. If we talk about the intracerebral lesion, to remember, intracerebral lesion, when I said the intracerebral cystic lesions, so there's a big number of list of lesions which include the dystroglycanopathy, LAMA mutation, pontocerebral hyperplasia. So all of these lesions or cystic lesions are occurring within the cerebral brain parenchyma. But you need to understand that's another big talk and we won't be able to cover it. So what we are going to focus today, so our focus remain on the extracerebral cystic lesions, which include the dentimochor malformation, inferior vermeer hyperplasia, black pouch cyst, arachnoid cyst, cisterna magna. So this is what we are going to talk about it. So before we approach and we go further discuss it, let's quickly revise the important anatomical landmark. I cannot emphasize to knowing the correct anatomy of your posterior cranial fossa, your brain stem, before you do the interpretation. Anatomy is the must. So, for all the residents and the fellow who are with us, just have a quick review of the mid-sagittal anatomy. We know we have the corpus callosum, we know we have the tactile plate, the brain stem, pons, medulla, orbix, which is the exit point of the fourth ventricle, CSF flow, and we have the fourth ventricle. So this is what the mid-sagittal anatomy look like. But if we further focus on this area, which includes the brainstem and the posterior cranial fossa and the corpus callosum, just look carefully. What are the important landmarks? The first important landmark is the normal tentorium orientation. So normal tentorium orientation is that the tentorium always make the 45-degree angle with the brainstem, and that's how we measure it. The other important thing is the insertion point of the normal tentorium. As we all know, trochula, which is the venous confluence, located at the inferior portion of the tentorium. That's the normal relationship. And if you talk about the trochular or lambdoid suture relationship, we know it is very, very important. So trochula is a little high or little low than the lambdoid suture. Now, talking in the continuation of the important anatomy landmark, let's focus on the normal fourth ventricle, the shape and the anatomy. It is very, very, very important. People don't pay attention to it. It is the key imaging. This is the key anatomical imaging landmark. Just look at the shape of the fourth ventricle. It is a triangular shape. And you just see the triangle, the cone or the apex of this triangular, it is making an acute angle, is pointed, and it's pointed into the cerebellum. So the pointed part of the fourth ventricle, which is pointing into the cerebellum or apex of this triangle, is known as the fastigium. So that's how your fastigium, and that's how the normal appearance of your fourth ventricle. Then another important landmark is the your tegmentovernian angle, which is the angle which we measure between the vermis after drawing the single line and the dorsal surface of the brainstem. It has to be no zero in a normal individual. Then talk about the vermis anatomy. Oh, sorry, the brainstem anatomy. So brainstem, we know we have the midbrain, we have the pons and medulla. But what I want you to remember, What is the normal size ratio? So always remember the length of the pons should be twice of that of midbrain and the medulla. So this is the relationship 1, 2, and 1. That is the normal length ratio of pons to the midbrain and the medulla. Then we talk about the posterior margin of the brainstem, which is this dashed line. It should extend from the caudal aqueduct to the obex, and it should be straight. It should not be deviated anywhere. It should be a straight line. Then if we draw a line, if just you want to see either the fourth ventricle is higher in location or lower in location, the way of measuring it, you draw a line from a vestigium, which is a triangular pointed area of the fourth ventricle, and it has to cross the lower one third of the pons. If it is crossing the mid of part of the pons or the upper part of the pons, that means your fourth ventricle is not at the normal location. Let's talk about the vermis anatomy. So how do we see the normal vermis? I'm not talking about the cerebral hemisphere. I'm talking about the vermis. So vermis is divided by a major fissure, which is known as the primary fissure. So this is the primary fissure. I hope you all can see. So what the primary fissure does, primary fissure divide the cerebellum in the anterior, or we also call it as superior vermis, which is a one third and or smaller portion, and the lower part, which is the posterior vermis or the lower vermis or inferior vermis. So always remember one thing: the anterior vermis is bigger than the posterior. The anterior vermis is a smaller than the posterior vermis. So their ratio is 1:1.5. The primary fissure, the portion of the vermis which is above the primary fissure is smaller than the posterior fissure. I just want to give you an idea with the example. So this is the cerebellar vermis hypoplasia. So look at this primary fissure and the anterior part of the vermis, which is also known as the superior part. It looks bigger than the posterior part, which is technically and should be larger than bigger in size. So this is the classical example of the cerebellar vermis hypoplasia. Now talking about the posterior cranial fossa anatomy of the cerebellum. So I won't go into detail, but the important thing which I want you to remember is, remember that the vermis is always centrally located, smaller in size than the cerebral hemisphere. Remember the contour of the posterior cerebellum, which is very smooth and regular. And another important thing which I want you to remember, the fissures. Can you see these myelinated fissures of the cerebellum? These always run parallel to the calvarium. So they should be the parallel to the calvarium, not having any perpendicular orientation. And when they do, then start thinking of the cerebellar parenchymal dysplasia or cortical dysplasia. So now we have discussed the gross anatomy and important anatomical landmark of the posterior cranial fossa. Now let me share you a systemic approach that I personally use whenever I report any cyst in the posterior cranial fossa. And this is consistent of these 6 simple checklist questions that always help me to make my interpretation more clear and more structured. So you are, if you and this is something that I always share with my fellows and with my residents, and always ask them to keep this checklist of 6 questions in their reporting area. That will always make their interpretation more precise, more clear, and more correct. So number 1 question is that what is the vermis morphology? Is it hypoplastic or it's not normal? My second question is that fourth ventricle either is enlarged, normal in location or not. My third question is the tegmento-vermian angle. Is it normal, 0 or not? What is the size of the posterior cranial fossa? Is it enlarged or normal? And then I look for the, is there hydrocephalus present or not? Last question is the occipital bone scalloping is present or not? So these are the 6 question checklists which I always use when I ever have a posterior cranial fossa cyst. So now let's try to solve the case number 1 with the help of these questions. So this is the case number 1. It's a male, 2 years old, presented with increased head circumference. What do you think? What is the diagnosis? So I'm sorry, I'm not entertaining the chat box in the question. Let me just try if I can. Okay. Okay, I'll take the question and the chat box. I'll see the comment. If you want to give me share any comment, please. I request the moderator to please do ask me. Is there any question that I can answer in between? So coming back to our case number one, so in this child, what can be the diagnosis? We all know that we are seeing a large cyst, but what is this? Always have a normal mid-sagittal view whenever you have any kind of cyst in the posterior cranial fossa. And now let's try to solve this case using our 6-question checklist. What is the vermis morphology? That was my question number one. Is it hypoplastic or normal? Look at the vermis here and just compare it with the normal. Of course, if we compare it this with the normal, this is smaller in size and showing the anti-clockwise rotation. Now, my second question, what is the size of the fourth ventricle? Is it large or it's normal? Look at the fourth ventricle here and look at the fourth ventricle. Definitely it is enlarged. My third question, tegmentovermian angle. This is the normal zero tegmentovermian angle. If we calculate the tegmentovermian angle, it is definitely more than 40. What about the posterior fossa? Definitely posterior fossa is, if it is the normal size, this is definitely large. Now, question number 5. Hydrocephalus is present or not? Look at this. This is the normal ventricular system. Definitely there is a hydrocephalus. And now finally the occipital bone scalloping, present or not, we can see there's a minimal, not really too much, but it's there. So if I summarize all these things finding, so these all are the characteristic imaging phenotype describing the Dandy-Walker malformation. So Dandy-Walker malformation, the elevation of the torcular or lambdoid inversion is also present. It's just look at, this is the area, this is the lambdoid suture, and this is the trocula. So this was a case of Dandy-Walker malformation. So exactly going back to our embryology, which is the key, because if you have the understanding of your embryology, then you know what's going on. So remember, this is what we were discussing, the formation of the Blake pouch at the 6th week of gestation. So if at this point, when the anterior membrane area or the posterior membrane area was found, any error occur at this point in the embryology, then we may develop the Dandy-Walker malformation. And the Dandy-Walker malformation, and at this point, if anything happen, any genetic abnormalities, for example, FOXC1 genetic mutation is present, or at this point, if there is any hemorrhage occur in the brain or any insult occur in the cerebellum, that can all lead to the Dandy-Walker malformation. Actually, that is hurting, or the error is occurring at the formation of anterior membrane area and the posterior membrane area. So always remember. So that's if error occur here, that this is the result of that. So you have to remember that anterior membrane area and the posterior membrane area is the embryological stage where if there error occur at this point, that can lead to the Dandy-Walker malformation. Now, the things which I want you to remember whenever you have Dandy-Walker malformation in your reporting, it's not only important to just describe it that you have the Dandy-Walker malformation. Always look for the associated abnormality, either the midline abnormality, neurocutaneous melanosis, fasces. All these syndromes are associated with the Dandy-Walker malformation. Even the trisomy 18 and multiple trisomies are associated with Dandy-Walker malformation. So it is very important whenever you look for the other abnormality than the cyst, so supratentorial abnormality, infratentorial abnormality. And it is very important to know the severity of the hydrocephalus in addition to the other associated supra or infratentorial abnormalities, because that predicts the neurodevelopment outcome in these children. So this is a paper this is recently published by the Barkovich and group. And why I'm just referring this paper, because as a resident, we all knew the size of the posterior cranial fossa and the trochlear location was always the part of, or it's a characteristic classic imaging features which are still described till date in different books. But according to the Barkovich and group, which they said, and this is a large paper, it's a very interesting paper to read, and they said that the posterior fossa size and trochlear location should be eliminated from the Dandy-Walker imaging criteria. The more suggestive and more reliable criteria for describing on imaging the Dandy Walker includes the Vermian hypoplasia, tegmentovermian angle, which you just say, quadrant Tedney location, obtuse angle of the fourth ventricle. So these are the more reliable feature. So it's not all the time that you have the trochlear inversion or the posterior cranial fossa size. So it was the least finding they found in their large cohort. So this is what I just wanted to give you the update about the Dandy Walker malformation. Now, coming to our case number 2, this is a female, 7 years old. Again, she presented with the headache. No other neurodevelopmental delay, absolutely fine, neurologically fine, intelligent girl, but she had that headache. MRI was done. What did you see? We can see a large cyst, again, not the big one, but a cyst in the posterior cranial fossa, which is extracerebral in location. Compare it with the normal. This is your comparison and look at this. So definitely there is an infravermian cyst or fourth ventricle. Just look at the shape of the fourth ventricle. Now let's try to again solve this case with our 6 question systematic approach. Again, my question number 1, vermis with morphology. Look at the vermis. If it is your normal vermis, look at this. Vermis is hypoplastic or not? Definitely vermis is formed, but it is slightly pushed upward or mass effect of over the inferior part of the vermis is seen. My second question, how is the fourth ventricle? If this is the normal fourth ventricle, definitely fastigium is showing the obtuse angle and it is definitely in charge. If we talk about the tegmentovermian angle, which is usually a normal, which should be normally 0. So it is definitely not 0. It is making the angle of 30, which when I measure. And hydrocephalus, is the hydrocephalus is present? Just compare it with the normal. Of course, we can see the hydrocephalus here. And talking about the last question, the occipital bone scalloping present or not? So really, no posterior occipital bone scalloping is present. So if we combine all of these questions, then the normal vermis, a large fourth ventricle, angle within 30 degrees, enlarged posterior fossa, all these imaging findings are suggestive of Blake pouch cyst. So this was the case. So what happened? Why the Blake pouch found? So I was keep saying you and I was asking you, is this the black pouch is a normal variant or not? So black pouch is a normal variant which disappear between the 6 to 12 weeks of gestation after the fenestration of the foramen of McGinty. Remember the formation of this black pouch when I was saying that form at 6 weeks and by the end of the 12 weeks of gestation, there's a hole appear, fenestration occur, and that hole is the foramen of McGinty. And from after that, there is free flow of the CSF occur from the fourth ventricle. If this pouch or if this pouch does not disappear because of non-fenestration and non-formation of the foramen of McGinty, so this black pouch persists, and persistence of this black pouch results in black pouch cyst. So failure or incomplete and non-formation perforation of the foramen McGinty after the 12 weeks of gestation can result in the black pouch cyst, not the black pouch. I hope things are clear. So just remember, so this is the case when during the before the 12 before or till the 12 weeks of gestation, the fenestration of the foramen McGinty was not occur, and this cyst or this pouch persisted as a black pouch cyst. So coming back to my first question, when I asked you earlier this question, that was the question, okay, dilated open fourth ventricle, normal size elevated vermis, mild hydrocephalus. What is the possible diagnosis? So answer of the question that I asked you earlier was the black pouch cyst. And I'm hoping that it's clear for everybody now. Now comes to my question that I asked you earlier, is the black pouch a normal brain malformation? Now we all know the answer. The black pouch itself is not a brain malformation. Answer is no. But the black pouch cyst is the abnormal brain malformation. So always remember that the black pouch is a normal immunological structure with non-rotated vermis. And remember that it's a normal finding in the fetuses and neonate and has no clinical importance in the absence of mass effect over the brain stem or in the absence of hydrocephalus. Black pouch cyst is something which is abnormal. It's an abnormal distension which happens when there is no formation of the foramen of Magendie occur, and that results in the mass effect over the vermis, and we say it is a black pouch cyst, and depending how much mass effect it is causing on the cerebellum and on the brainstem, the size and how much obstruction of the CSF flow it's causing. And sometimes you will see the patient with isolated black pouch cyst. If this is a very small cyst, they have the very good prognosis. So actually, the size of the black pouch cyst and its mass effect matters a lot. Coming to our question number 3, or case number 3, another female child with headache. And these are the findings. Compare it with the normal. This is your normal, and this is the case. Of course, we can see a large cyst, and there is a displacement at slightly smaller size of the vermis. And you can see this in the axial section. This is here. Now, let's try to solve this case number 3 with, again, our 6 questions, a checklist. So again, look at the morphology of the vermis. How is your vermis? The vermis is slightly smaller in size as compared to this full-size vermis. Look at the fourth ventricle. Fourth ventricle is definitely grossly enlarged. Tegmentovermian angle definitely is not 0, which is a normal thing. Posterior fossa really is not enlarged, but the cyst is there. Hydrocephalus is there, maybe slight hydrocephalus is there, plus minus. Is there any scalloping of the occipital bone? Not really if I compare it from here. So all of these findings, which I just described, are suggestive of isolated inferior vermian hypoplasia. So this, just look at the size of the inferior vermis. So what is the embryological problem? So again, recalling the embryology, embryology, and embryology. So any defect, if occurred during the formation of anterior membrane area or the posterior membrane area, if the both error occur at this level, this may either result at the formation of the Dendy Walker or the vermian hyperplasia, depending upon the amount or severity of the insult. So remember, I said, if, again, just a simple recall, any defect in the embryological life occur during the formation of the AMA on posterior membrane area, if it's a mild insult, that may result in the inferior vermian hyperplasia. If it's a severe insult, then that can lead to the Dendy Walker malformation. The people that are talking about, as you know, many of you who are involved in the brain imaging, they know that most of the time the inferior vermian hyperplasia is most of the time is a incidental finding. And then we really question, should we report it, and how should we emphasize on the importance of it in our report? So again, if you talk to your neuro friends, they will say that the presence of the inferior vermian hyperplasia has a controversial outcome. It can be an incidental finding in a normal person, but sometimes some of the individual may have the mild functional deficit, fine motor activity, and receptive language problems. But it's in only the 25% of the patient do have this problem. But rest of the 75% patient, this can be a simple, mild insult during the embryological life and can be an incidental finding. So you have to keep in mind and ask them to correlate it clinically with the neurological symptoms of the patient. Now, coming to the course, our case number 4, it's a 16 years old with the history of fever. So it's one of my on-call cases, and I was just looking at it, and I was like, I saw there was no signs of meningitis. Trust my words, there was no meningeal enhancement. They only asked, the patient was absolutely fine. Look at the age, absolutely healthy but boy, and now having the meningitis and fever, and they are not having any history of fits, no neurodevelopment disorder, nothing. When I was reporting, I found this cystic area in the posterior cranial fossa. Again, I was questioning, what is this? This is something which is not normal. Just compare it with the normal. There shouldn't be anything behind the vermis or inferior to the vermis, but yes, we can see it. And now, let's start solving this case with our 6 questions. How is the vermis? Look at the vermis. The vermis is absolutely looking normal. No problem in the vermis. Look at the fourth ventricle. Absolutely normal looking fourth ventricle. Look at the tegmentovermian angle. Absolutely 0, almost normal. Posterior fossa. It's not really enlarged as compared to the normal case. Look at the hydrocephalus. No hydrocephalus is there. Look at the occipital bone scalloping. No scalloping there. If everything is bilkul or is almost same as of the normal, then what is this cyst is? The answer is this cyst is the mega cisterna magna, which is again a normal finding. So why the cisterna magna happens in us in many of the humans as a normal finding? So black, if remember again going back to the embryological life, if during the posterior membrane area formation, if there is delay, if no perforation of the foramen of Megandy occurs, then it results in the large black pouch cyst. But if the fenestration or the hole or perforation of the foramen Megandy occurs slightly late in the posterior membrane area, this black pouch persists for a long time and remain as a mega cisterna magna. So that's the reason this mega cisterna magna can be an incidental finding in many of the patient, because in these children the perforation of the foramen of Megandy occurs after the 12 weeks of gestation or little late. Then isolatedly, if you find this finding, we all know it's half of the cases or many of the cases having a megacisterna magna is just simply a normal finding, and usually they all have the normal neurodevelopment. Now, question number 3. This is the question that I asked you earlier. So when you don't have anything which is absolutely fulfilling the criteria of the Dandy Walker, but there's a cyst, so people start using the term, or they do use the term Dandy Walker variant, Dandy Walker malformation complex. Do you think is this the right term to define the black pouch cyst, inferior vermian hyperplasia, or magna magna? What do you think? And this time, I really want you to see what you all are thinking. Tell me, do you think is it appropriate to use this word? I'll be happy to see the answers from my everybody. What do you think? So, if we talk about it, using the word Dandy Walker variant or Dandy Walker complex continuum is not really a good term to use. Why? It's a quite ambiguous and confusing term for your neurogeneticist, your neuroradiology colleague, your neurosurgeon colleagues, because it's just simply nothing for them. People are you in past or conventionally or usually the old school of thought is that using the term of Dandy Walker complex or variant for the isolated vermian hyperplasia, black pouch, and megacisterna mega. Don't use this. It's just a confusing term. My interpretation tip to you, if you have something like that and you're not sure if it is not forming the Dandy Walker criteria, then try to use the clear description and the best characterization of the cyst that you are seeing at the posterior cranial fossa, finding when but as much as clear as possible. And sometimes it's not easy to just say exactly it's a cisterna magna or it's a black pouch. Sometimes it's very difficult, but try to be as precise as possible anatomically in your report. A complete anatomical description should be made in your report if you are not sure, instead of using the word Dandy Walker complex or Dandy Walker variants. Coming to the case number 5, it's a case of 17 years old me. Again, neurodevelopmentally absolutely fine, no history of affairs, no abnormal neurological symptom except the on and off migraine. MRI was performed and see a large cyst was here. And just compare it with this normal control. So you can see there's a large cyst is present, causing this significant mass effect over the vermis. Now, again, let's try to solve this question with our 6 questions. How's the vermis? Vermis is formed normally or not? Look at the vermis. Vermis is formed, but it's pressed by the cyst. Look at the fourth ventricle. It's just compressed, but it's normally formed. Tegmentovermian angle is again absolutely zero. But there is a cyst in the posterior cranial fossa, which is making the posterior fossa a little enlarged. And the last question, hydrocephalus is there or not? Yes, there is mild hydrocephalus present. And then the scalloping of the bone, a very important question. If you compare this bone, I hope you all can see my arrow, there is a scalloping. So whatever thing is there, whatever the cyst is there in posterior to the vermis, it is causing the mass effect. It's a chronically there and causing this scalloping and remodeling of the bone. So all these features are suggestive of arachnoid cyst, not the cisterna magna. Now, the most and a very one key treatment challenge arises whenever we have the questions between the cisterna magna or the arachnoid cyst. It is sometimes when they are enlarged, it is sometimes very difficult to differentiate the cisterna magna with the arachnoid cyst. Why? Because while both can appear similar, as the, probably sometimes the arachnoid cyst is enlarged, it may show the bone is scalloping, but if it is not, then there's always a question and there's a confusion. Is it a cisterna magna or arachnoid cyst? What I do when I'm not sure, I always say if there's no arachnoid cyst, always just write it's a small cisterna magna or it's a arachnoid cyst. But if it is enlarged and causing this significant mass effect that can lead to the CSF obstruction, which is all the time is the arachnoid cyst, not the cisterna magna. And at this point, the treatment challenge comes. And here is the time when your neurosurgeon comes to your reporting area and asks you, is this the black pouch cyst? Should I go? Oh, sorry, is this the arachnoid cyst or is this the cisterna magna? If you're going to say it's a cisterna magna, they are not going to intervene anything. Or it's arachnoid cyst. If it is the arachnoid cyst, definitely they are going to puncture it, they are going to remove it because it's causing significant mass effect over the brainstem. So how, as a radiologist, we can help them to differentiate between the large cisterna magna from the arachnoid cyst? They will ask you, should we go for the MR spectroscopy? Should we go for the MR cysternography or CT cysternography, or should we go for the MR CSF flow study? What do you think? What should we do? Tell me. Are you going to do which? Okay. And very good, Masood. I agree with you. We should go for the MR CSF flow study. So again, if your surgeon is asking you because that person because the surgeon is confused either he should surgically intervene or not. So remember, in the CSF flow study, cisterna magna is a simple extraaxial CSF space, and it always communicates with your fourth ventricle, and it does in the when you perform the CSF flow study, it will not cause any obstruction. But while arachnoid cyst, in cases of arachnoid cyst, it will cause the obstruction. As you can see in the CSF flow study, it is causing the CSF flow obstruction, and you will see there's a proximal, there's a hydrocephalus there. So whenever a neurosurgeon asks you and they have the treatment challenge, either go inside or not, do the CSF flow study. If there is a flow obstruction, that they have to go inside and remove this obstruction. So yes, at a times, not all the time. If you are not sure, ask for the CSF flow study. As you can see in this case, cisterna magna, there is continuous continuation of this megacisterna with a CSF flow, and there you can see the continuous flow of the CSF is seen at the craniocervical junction, as contrast to the large arachnoid cyst, which where you can see it is causing the mass effect and obstruction in the CSF flow at the craniocervical junction. And at this point, your neurosurgeon has to go and do some intervention. Now, that was the question that I asked earlier. For a cystic brain malformation, the degree of neurodevelopment delay, cognitive outcome are related to what? Dysmorphic hypoplastic vermis, supratentorial abnormality, or severity of the hydrocephalus. What do you think? What could be the answer? Your neurodevelopment outcome stored depends on what? So again, the answer is abnormal neurodevelopment is related to all of them. The progression of the hydrocephalus, the severity of the hydrocephalus, abnormal pericardial abnormality, dysmorphic or hyperplastic vermis, supratentorial anomalies, structural malformation, all has impact on the neurodevelopment outcome. For example, this is one of our recent cases while we were reporting it. So you can see a black pouch cyst is here. The vermis is, the fourth ventricle is enlarged, communicating with this. Vermis is totally formed. But just look at this associated supratentorial abnormality, which is showing the pachygyria, abnormal white matter because of the malformation, cortical malformation development. You can see the cortical dysplasia or cortical malformation in the cerebellum as well, to look again and again for other findings. Prognosis and risk of the aneuploidy are very different if multiple abnormalities are present. So it's very, very important. If you see the black pouch cyst or any cyst, look for the additional supratentorial abnormality. Again, another case example. This was the case where while we were reporting it, we were seeing a small, you can see the vermis hypoplasia. Of course, it's just a vermian hypoplasia. But my question is again, is it an isolated vermian hypoplasia? The answer is no. Just look at In addition to this vermis hypoplasia, supratentorial, it is associated with the corpus callosum agenesis. And if you further look up, you can see the significant generalized polymicrogyria is there. You can see diffuse involvement of the uh, parietal lobe, frontal lobe, and occipital lobe with the polymicrogyria. So look and look again for the other finding, because if you see any cyst, look for the additional finding, because it's going to impact and going to predict the neurodevelopment outcome in these children. So at the end, this is one of my favorite slides. My residents know this, my fellow knows this all the time. On my desktop, and my reporting desktop is always there. So I always just use this checklist, and I'm very grateful for my friend Kishmankan, who works in the Great Ormond Street Hospital. He shared this slide with me. So I use this checklist, look at the vermis, look at the fourth ventricle, posterior fossa size, hydrocephalus, tegmentovermian angle. And this is the criteria which always help me to make my report more precise and more correct and more easy to understand for my neurology and neurosurgeon colleague. And if you want to take the picture of this slide, you are allowed to take it, and you may use it in your reporting area as well. And with that, thank you very much. I'm really grateful. If you have any question, I'm happy to take the questions. Thank you.